Hello, my name is Diana Nicole Chiriguaya Palis, and the topic to be discussed is proximal strain and functional testing applied to patellofemoral instability. Definitions. Patellofemoral instability can be defined in different ways. One way is when the patient has undergone traumatic dislocation of the patella. It can also describe a scene of physical examination, signifying the ability of the patella to be straightened or the tracheal growth of the femur in a passive manner. Moreover, patellofemoral instability can be symptoms with the patient feeling that the knee gives way. Proximal strain. So when we focus on proximal strain and stability in the muscle closer to the center of the body, we are helping to spurs from movement in the part of the body further away from the center, distal body parts.
Hi, Dr. Steve Gary with Stebbin Hawkins Clinic of the Carolinas. Really, we're talking about kneecap instability or patella instability today. And with any joint, when we say instability, we mean it goes past normal. So we have some inherent flexibility or motion in our joints, and if it goes past the normal point, we call that instability, and that can be a partial coming out of joint, which we call subluxation, or completely coming out of joint, a dislocation. And so specifically in the knee, in the patella, this can be, majority of the time, this is something that can go out to the side if it goes past point, if you will. Meaning normally it has some inherent balance on both sides of both the muscles in the quads above and the tendons around the kneecap. However, if the patella, quote, slips out of place, that's something that usually happens to the outside, and it can be a spectrum from a partial or subluxation or a complete dislocation of the kneecap. When that happens, there can be blood in the knee, pain, stiff, swollen. About 10 to 15% of the time we can chip off a little fragment from under the kneecap, and that which we call a loose body, and that can be a bony cartilage fragment. If that exists and it's big enough, then sometimes we have to remove that. The initial treatment is usually trying to calm down the knee, so reduce the swelling, restore the motion, and getting the quads muscles firing again. Usually that involves some type of bracing, either and possibly even some immobilization, but usually into a patella brace, which creates some force on the outside part of the kneecap to kind of keep it at home or vector that way, but still allowing motion to be restored and then quad strengthening to be restored. So that's kind of a sequential program of bracing, progressing activity to some quad strengthening, and then ultimately getting folks back to more exertional force, first linear, and then some change in direction activity, and then ultimately sport-specific cutting and pivoting activity. The majority of times with a first-time or initial dislocation of the patella, we are engaging in that conservative treatment. Even though there is some soft tissue injury about the knee when that happens, for the kneecap to go out to the outside part of the knee or laterally, like in this right knee, there has to be some injury to soft tissue on the other side. And so even though we rehab this, if it becomes a recurrent dislocating kneecap, then sometimes we are engaging in surgical treatment to tighten things up on the injured side and sometimes loosening on the other side. Subsequently, people are back in a similar kind of rehab approach where we're progressing their motion, their strength, and then ultimately their physical activity, and usually with some temporary bracing and transition. Thank you.
Application in physical therapy. Hip isometric strain with assay with handheld dynamometry and utilize reinforced straps. Each strain measure was scaled over to maximum 4 train after one practice train of 15% for. Moment and length was recovered for each test and used to determine torque. Feature 1. Higgs external rotation test position for maximum strength assessment with hand dynamometry. Figure 2. Higgs section test position for maximum strength assessment with hand dynamometry. Figure 3. Hip abduction test position for maximum strength assessment with hand dynamometry.
Demonstrates the patella apprehension test for patella dislocation. Hi and welcome back to Physio Tutors. Dislocations of the patella are a fairly common sight in sports, and Kai has experienced it himself during his active soccer career. While these are usually traumatic incidences, genetic predisposition can play a role as well. Factors that may influence the risk of dislocation are, among others, the sulcus angle and sulcus depth. Nunes et al. From 2013 conducted a scientific review and meta-analysis on clinical tests for the diagnosis of patellofemoral pain syndrome, which included the patella apprehension test. Upon pooling, the positive likelihood ratio for the patella apprehension test is reported at 1.3 and the negative likelihood ratio at 1. Which is why we attribute the weak clinical value to this test. To conduct the test, the patient is either lying supine or sitting on the bench with the knee flexed to 30 degrees. The quads should be relaxed to allow passive movement of the patella. With the thumb of both hands, press on the medial side of the patella to exert laterally directed pressure. In a positive test, the patient may be surprised by the lateral displacement of the patella and feel uncomfortable or apprehensive as the patella reaches the point of maximal lateral displacement. The patient may even reach for your hands or attempt to straighten the knee to pull the patella back into relatively normal position. Now, if you want to watch another video, we recommend the patella grind test, which you can watch by a click or tap on the left. A summary of all clinical tests published. I'll see you next time. Bye.
Pros and cons. Although conservative treatments provide results in our patients with EPF should be treated surgically. To this end, more than 100 surgical techniques have been described. This treatment combines a series of procedures such as lateral retinaculum release, medial imbrication, distal realignment, circuloplasty, and treatment of the tibial tuberosity to a more medial and anterior area. Some of these techniques can be performed using arthroscopy, open and combined procedures. Issues play in Ecuador. In the USA, it has been reported that patellofemoral dysfunction (DPF) represents to the 20% to 25% of knee pathologies, and that represents 1 in 4 injured knees in sport clinics. According to data from the Ecuador Ministry of Health in 2016, of the patients treated in the Halting House with the musculoskeletal disease placed the knee as the second cause of consultation in the country. Conclusion. We conclude that strength endurance and limb functional tests assess different aspects of muscle function. Additionally, core endurance may be more important than hip strength when evaluating individuals with lower extremity dysfunction. Clinical show utilize tests in combination with, say, individuals with lower extremity dysfunction in order to gain a greater understanding of patient functional limitation. Further investigation of this factor in a patient population with patellofemoral disability will be needed.